In some different countries, they don't have access to cardiac care at all. So it is, they don't have 911. They don't have an ambulance to come and get them if they need. So they travel for days to get to a clinic to get the cardiac care they need. And then if they are told that they need a heart surgery or some kind of minimally invasive procedure, a cath and things like that, they have to wait weeks and months and months.
Welcome to the Open Notes podcast. Our study group includes me, Nora Mortimer, Kiana Gerhart, hello, and Angela Thompson. Our guest today is Dr. Monica Sanford, Doctor of Nursing Practice and Adult Gerontology Acute Care Nurse Practitioner. Grab a snack and your notebook and let's get ready to study. All right, so we have some icebreaker questions, but they get a little deep in my opinion. So, can you introduce yourself first?
Yes, thank you for having me. So, I am Monica Sanford. I'm a doctor of nursing practice. My son was born with a congenital heart defect about 25, well, he's 34 now, but after he was born, I went on to be a nurse, bedside nurse, and advanced practice into nurse practitioner, acute care nurse practitioner. And then went on to advance a terminal degree for a doctor in nursing practice. And everything I do is inpatient cardiology. I do see patients in cardiology at a local free clinic. So everything I do is passion driven and purpose driven to help cardiology patients and take care of cardiology patients in the community and in the hospital and any way I can. So, but thank you.
So, Monica, where did you grow up and how did you what were you doing before you became a nurse, I guess?
Yeah, no, I was born and raised in Houston, Texas, and I moved to Florida, and that's where I met my then husband, now husband. I met then my husband, and he was in the Marine Corps, and he's retired Marine now after 25 years in the Marine Corps. And we've been married 35, and we got married, traveled around with the Marine Corps, and I did business back then, business and marketing. I worked in marketing at different big box type electronic places. They don't even have them anymore. Circuit City was big back then. So marketing, advertising, sales, things like that. So I was in business stuff. And then we got married, had our first son, and our first son was born, like I said, with a congenital heart defect. So it completely changed the trajectory of my purpose, my life, and things like that. So it went from business, and my first degree was in business management. And so I had a degree already, so I could do the jump into a nursing program with some of the fundamentals already done. So it was a complete trajectory change in my life going into nursing. And then from then on, it was just, I do use my business background and leadership background, marketing background in the clinical aspect sometimes. I love having both backgrounds, but so yeah, I was business before I was nursing.
I feel like you are very involved in advocating for a congenital heart disease because of your son.
Yes.
So, what does it look like for someone like a parent or like a relative taking care of their kid, or even just in general? Like, how is the care for
Yeah.
someone, or how can you identify something like that?
Yeah, it is identifying, you mean the clinical needs of a child. It's when someone's first born. Definitely, yeah. If you have a child and all of a sudden they are working to breathe, working to eat, they're not eating as, they're having to gasp while they're taking a bottle or breastfeeding, things like that. And you see this is, they're not gaining weight, they're sweating while they're eating. That's overworking type thing. That is 100%. You need to immediately take that baby into your provider, take them into the ER, take them to be seen somewhere. So that is identifying so they can get an echo and really check out the baby. And sometimes it's benign and there are very simple to very complex congenital heart diseases. And it's the heterogeneity of that community. Every single baby is so different. So just, yes, go be seen. And if everything's great, wonderful. And they can figure out what's going on. But the care for the baby after that is management of their medications, management of their physical limitations, functional abilities, them in school. That's the same thing that any parent would go through, except you're going to have definitely a lot more hospital visits and clinical visits and things like that to really keep on top of their management. But I will say, from a mom's standpoint, you almost live in this state of you have you're always anticipation. It's always anticipating what is coming next. What am I going to have to? You keep an eye on certain things, and you're going, something is about to happen, and I need to be prepared for it. So that's why I went back to nursing school. And I will tell moms out there, knowledge is power. Educate yourself, look into things, join support groups so other moms around you. Because back 35 years ago, we didn't have this internet type thing where there was so many support groups and so many resources. And now I'm part of a few of them. So we do resources and outreach to congenital families to let them know what is available and where the specialty providers are, and the resources they can have access to.
I work at a community college, and
Yep.
I often have students coming in that are older that want to take the step to transitioning into a new career path. Did you find it hard for yourself to do, or like do you have any advice for those kinds of students?
I love that because I have taught at a community college, and I teach now I'm faculty at University of West Florida, and I teach health policy there, advanced health assessment, pathophys. And we also get a lot of older, actually a nurse yesterday, she brand new nurse, still in nursing school, came up to me in the hospital, and she said, this is a second career for me. And I know I'm 45. And so I love it. And it wasn't difficult for me because I knew instantly what I wanted to do, and I just dove in head first. It was so I love anybody that can transition. If as long as they can find their what they really want to do, they are going to love it. Nursing is a great career. Uh, and it's very mobile. You can go anywhere, very portable, especially with the military family. I could work anywhere we were stationed. It's very rewarding. It's almost like this secret you have, how to save somebody's life if you have to, type thing. So it's very rewarding and very comforting to know. And it's almost, there is a selfishness about it that you are helping somebody, and it helps you more. It like fills me inside better when I help somebody, type thing. It makes me feel better. And that's my patients at the free clinic. When I see them, they are so appreciative because they know everybody's there free. So I love seeing my patients at the free clinic. So having that ability, that knowledge that you can help somebody get better, educate them on their diabetes, their high blood pressures, things like that, that is very rewarding. So, and if they can choose, the nurse I met yesterday, she wants to do labor and delivery. Thank goodness I could not do it. That is not my forte. But yeah, if they go in with knowing a specialty or not knowing a specialty, they will quickly realize, I think, what they are going to want to do when they are going through their clinicals and they are taking care of babies, and they're like, oh, I love this, or no, I can never do this again, that type of thing, or I want to take care of this population or that population. So yeah, I welcome anybody. And it's not, my son has told me, Mom, you have been in school every decade of your life. So yes, it is constant. So definitely give nursing a try.
You mentioned your work at the free clinic. How do societal factors impact health disparities, specifically as it relates to cardiac care, but in nursing in general?
Of course, in the clinic too, we use all the evidence-based practices. We use all the scientific statements and the studies and trials and everything. And in my free clinic, we have an entire pharmacy, so we can have access to the medications, which I love, but some don't. But in that clinic area, I take it into account with all my patients, whether they're in the hospital or the free clinic. But like I said, you take into account all the social determinants of health. Some patients at this free clinic ride their bike there, or walk there, or ride the bus there, things like that. I have gone to mayors and city council and county commissioners saying, don't take away my bus route to here. This is how my patients get to this free clinic. So it is that, so we try to transform their care and their ability to care for themselves. So we take into, when I say these social determinants of health, it is all about not just education, educating the patient and their level of education, but getting to where they are, taking the care to them in their areas of need. But the geographical location, do they have refrigeration? Am I going to give them medication if they don't have a fridge, if they're homeless? Things to that. We take into account everything, the affordable housing, like I said, are they homeless or not? Do they have the refrigeration? Do they have transportation? How did they get there that day? One of my patients that I saw a couple of years ago now, he rode his bike all the time to the free clinic, and then he couldn't ride his bike anymore because he was having chest pain. And that's literally how I'm like, wait, the red flags start going off. And he said, I'm too short of breath and I just couldn't ride my bike today. So I had to ride the bus. And I said, I'm sending you for a test. So I sent him for a test and he actually had to go have bypass surgery almost immediately. Within 2 weeks, all of this was done. So one of those, we take into account just everything about the patient. And like I said, we have the pharmacy there with the medications, or we can get the medications with what we call the PAT program, the patient assistance program. But so yeah, the community itself, we have to identify as nurses. We do a great job of identifying those barriers to that access to care. So we identify the barriers that patient has and customize that care for them. We try to optimize their entire plan, patient driven, patient centered. We discuss it with them, and then we have to customize it to what access they have or any barriers they may have, and identify those barriers and identify other opportunities. Do they live in an area where there's a food desert? They have no grocery stores, things like that. So yeah, it's full time, and we've have a whole village. Like I said, it takes a whole village. It takes a whole team. We have our case manager in the hospital or at the free clinic, things like that we can rely on. And I cannot say enough about. I'm sure y'all have had a case manager on before, but they do miracles. So, or any of y'all may be a case manager. Sorry, but yeah, social work case manager. I don't see how they do what they do. They have resources in their Rolodex in their brain. So is Rolodex a outdated term? Sorry.
No, not in my world.
Not for us.
They have it in their smartphone. Let me put it that way. So.
Mm-hmm. So, how do you think society shapes those barriers or even like patient behavior towards seeking help?
That's a great question because it is. I have the part of the free clinic, myself and a physician. She was an OBGYN for 35 years. Me and her and or is that correct language? Me and her. Anyway, both of us and the director of the free clinic got together and wrote a grant. And the grant was for cardiac care outreach to minority communities. So we won the grant. It was $100,000. So that allowed us to go to the communities, go where the patients live and work and play and walk and things like that. So we went to the churches, barbershops, their festivals. A big one was the Martin Luther King Barbecue Day. And we went out there and big, huge community outreach that day and have everybody just come by the booth, get your blood pressure taken, please. That type of thing. Get some education on blood pressure. So it is because we have found that certain communities just are afraid. One, they don't want to come into the hospital. They don't want to go to their clinic or their primary care. They don't have access to one, but they don't want to know their blood pressure. They're so afraid to know what their blood pressure is because then they will have to treat it or they will. So a lot of education goes into these outreach kind of seminars and outreach kind of things that we go to. We went to ladies' church groups, and probably that was one of probably the biggest ones we had was a ladies' outreach at the church. Filled the room, their hall that they had there, and took everybody's blood pressure. And of course, I do the cardiac education, and the other physicians and nurses take the blood pressures. And so it's a wonderful experience. And it was actually such a great, so that was 2 years ago. And then the data that came in was so overwhelming that it was from Amgen. It was Amgen Pharmaceuticals, and they loved the data so much that they did it for another year for our free clinic. So, and the nurse that runs all the data, she's amazing. But the societal that when I say they are very hesitant to come into the clinic, they don't want to be used as guinea pigs. They don't want to be lied to. They don't, when I say they, it's like anybody that has these feelings. But definitely I'm half Mexican from Houston, Texas. My mom's side of the family is from Monterrey, Mexico. And so it is the Hispanic community too, Latino communities, the Black communities. And this grant was actually called Outreach for Cardiovascular Outreach for in the Black community. So we went literally to where they were, to where these patients need us to go and cut down that barrier to that access. So that is huge, important. So, and another big one attended was a bunch of men in a barbershop. At the barbershop, the men would come because they felt safe there, they felt comfortable there, and they would come and listen to education and get their blood pressure taken. We just so happened to, at the time, have a police chief, Black male, and he came and got his blood pressure taken. And he was like, okay, everybody has to do it now. So, and it helps when you have the community support and society coming in saying, everybody, there's no shame. And if you have high blood pressure, now we just need to treat it and manage it, because you can't manage your numbers if you don't know your numbers.
And I'm really glad you mentioned the fear that exists in some communities. If you think back to like the Tuskegee experiment and those kind of things, that there's a social and psychological holdover from that people fear that people have from what they knew happened in the past. Trusting people in the medical community, and they weren't always treated the way they should have been treated.
100%. And now we see that a lot with Hispanic Latino, that they don't want to come in because they're afraid they'll get immigration called on them.
Mm-hmm.
They do not want to be seen and get taken care of. And we urge them, you have to come in and get your medicine. You have to come in and for your management. So it is, what the word you said is spot on. They have to trust their medical provider. And so one of those ways is building trust is going out to them and helping build trust and saying, I'm coming to you. I need you to, because I don't want you to have to come to me in the hospital having a stroke, or having a heart attack, having things that can be. So a lot of our education is preventative care, preventative medicine. And so that is lifestyle modifications, preventative care for their lifestyle. So no, I love that you said that. It is building trust.
So. Do you have any insights into how cardiac care and patient interaction may differ in other countries? Do they approach it the same way we do here, or is it a very different?
I sat on a panel for global disparities in healthcare at a national convention, and it was almost shocking. And I had already spoken with these cardiologists, and we were on a panel, but then one of them presented in some different countries, they don't have access to cardiac care at all. So it is, they don't have 911. They don't have an ambulance to come and get them if they need. So they travel for days to get to a clinic to get the cardiac care they need. And then if they are told that they need a heart surgery or some kind of minimally invasive procedure, a cath and things like that, they have to wait weeks and months and months. If you come see me in the hospital and you need a cath, you're either going within 20 minutes, we have you in the cath lab, or you're going the next day, something like that. And if you have to have open heart bypass surgery, we put you on for that week, and we put you on for the next day or the next few days, things like that. But in some countries, they do not have access to the emergency care and the preventative care, the primary care, or they're waiting for months and months for it. So a lot of it, and a lot of the nurse practitioners actually are going to these other countries to do the educational outreach. So nurses are huge in other countries, and nurse practitioners, because in nurse practitioners in other countries can practice autonomously, independently, almost like their town physician type thing. Now, I couldn't do what I do without my physicians. I love my physicians. I cannot practice critical care cardiology autonomously, independently of my team. Because if I need something, I call my doc and they're taking them to cath lab or they're taking them to surgery. But in other countries, they're doing a lot more independent clinical evaluations and treatments and procedures than here in the United States. So, which is a big push for here in the United States to say these other countries are doing it and having excellent results. We need nurse practitioners here to have more autonomous practice, more independent practice, mainly in Florida, where I just moved from. 3 years ago now, they just got autonomous practice, meaning or independent. If you are after a certain many hours of practice and being under a physician care or protocol, then you can apply to be an independent nurse practitioner in the state of Florida. So, and that will, you can open your own practice and you can practice independently. Still not full practice authority. Some states have full practice authority that I'm not sure what all state everyone's from, but a lot of the nurse practitioners in some states can have full practice authority on anything they want to practice. So we're leaning that way just because we see one, it doesn't increase litigation at all. It helps have access to care. We're still practicing as a nurse practitioner. I still follow the same evidence-based practices, the same national guidelines, the same time scientific statements and things that a physician would. But again, I love my physicians, and so I can't do what I do without them, but some can in primary care.
Is
So
that one of the reasons why you chose nurse practitioner instead of cardiologist, like the doctor physician side?
I toyed with the idea definitely, but it was my son is still very he's very independent, and he went to college. He graduated with his bachelor's, but he still has a lot of special needs that I going on to at the time, and I think if I would have been a lot younger and knew what I knew, I probably would have gone the medical route, the medical doctor route, but I don't know. At the time, I said, this is the best thing for me. I want to be a bedside nurse and then advance my degree into acute care nurse practitioner and then advance my degree with a DNP to be able to still advocate and publish and take care of my patients so I can be well rounded and still do what I do and still have a life, for one. I have a niece and a nephew. God bless them. Thank goodness they are physicians, and it's a lot of time. It is, they have devoted, and that's why I love my physicians. They devote their life and time and just their entire being to the hospital and care. So it's a big commitment. It's a big commitment. Not saying I would never do it. I'm like, when I hit 60s, I'll have to go back to school for something. So I'm about to hit 60. I can, the next decade of life, maybe go be a physician. I don't know.
Yeah. I love that. I was on my journey towards being a physician with a specialization in medical examining, so like
Oh, wow.
autopsies and things,
Yeah.
only because of that work-life balance. It was better in that field, and I was like, well, I'll never run out of a job because people are always dying.
Yeah. No, I love that because one of my influences, well, that's true. You laugh at it, definitely. Well, very much
Yep.
needed. But one of my influences when I was young was, and y'all probably won't remember this, but that Marcus Welby, MD. That was
Mhm,
literally the
mhm,
show I
mhm.
watched. Yeah. I
Yep.
was like, oh my gosh, I want to learn how to do that. But now there are nurse practitioners in smaller rural areas that are the medical directors. They are the medical examiners and the medical directors of their clinics and the medical examiners. And so yeah, they are, I forget their certification, but yeah, that's an amazing, one of the first ever classes I took as a nurse practitioner. I had to take gross anatomy. I went to Georgetown for my acute care NP, and we had to take the gross anatomy with the med students. So one of the first classes I took though as a nurse is they came in and just brought in a box of bones and literally said, put this patient together and tell us what they are, male, female, how old they are, what they passed away from. It was something that I was like, this is cool. So yeah, it's investigative nursing. So I loved it. So cool. Yeah, you need to go back and do that. That's fun. Yeah, it is. It's a huge commitment. It's a huge time commitment. It's a huge mind. I don't say mind suck, but yeah, it takes all your faculties. So, because I know my why. I have a post-it note that I carry in my lab coat with me that says, "Never forget why you started. Always remember why you started," type thing, and why you do what you do, and surround yourself with people, like-minded people. So when I'm in the hospital and everybody's in cardiology and all the purpose of everyone is my why type thing, it's just very empowering.